Good afternoon, everyone. Uh, I'm Dr. Nilanjan Bhaumek, consultant at Deenanath Mangeshkar Hospital. This is the third module and the last module for the laryngology webinar, covering a very important topic of swallowing. So we welcome all, and today's speakers would be myself and Dr. Sachin Gandhi, Dr. Manish Munjal, and Dr. Brushali Desai. So welcome all delegates. Uh, this following session would be conducted in two different halves. This is today's topics would be in four different lectures, and the next topics would be covered in December. Swallowing, like voice, like airway, has gained increasing importance over the last 8 to 10 years, and it's increasingly becoming a very prominent subspecialty of its own. So pay attention and welcome all.
Thank you, Dr. Nilanjan Bhaumek, sir. Welcome all delegates. Our first lecture would be by Dr. Bhaumek. A few lines about Dr. Bhaumek. Dr. Bhaumek is a qualified ENT surgeon with experience of 12 years in the field of otolaryngology. Since 2011, he has been closely associated with the Department of Laryngology, Deenanath Mangeshkar Hospital. He has a keen interest in swallowing disorders, snoring, and sleep apnea disorders. Besides this, he has a special interest in airway disorders. He believes that uh, a, a good quality of life is a right of every patient with airway and swallowing or swallowing disorder. Apart from his achievements in airway and swallowing, he has a keen interest in reading and is a has a very good collection of books. We welcome you, sir. Over to you.
Thank you very much, Darshan. Am I quite audible?
Yes, sir, you are audible.
So thank you very much. On that note, we start with the very first lecture in the swallowing module, that's on transnasal esophagoscopy, or TNE as it's fondly abbreviated. Now, TNE has got quite a fascinating history. The first esophagoscopy was performed by Dr. Adolphe Gusmol in the 1860s, who, when inspired by sword swallowers, performed a makeshift esophagoscope, and that was how the esophagoscopy was born. But then it was this gentleman, Dr. Chevalier Jackson, an eminent laryngologist, who actually popularized the procedure and did hundreds or probably thousands of them till the early 1950s. Then something radical happened. Dr. Basil Hirschowitz, who was a gastroenterologist himself, invented the first flexible fiber optic endoscope. And from then on, esophagoscopy slowly slipped into the domain of gastroenterologists. Then in the early 1990s, Dr. Reza Shakir, who was a gastroenterologist himself, performed the first esophagoscopy through the nose. Dr. Jonathan Aviv, in the late 90s, again demonstrated to an audience the first TN, the transnasal esophagoscopy. And from then on, early 2000s, laryngologists again started performing esophagoscopies, especially through the nose. Now, this TNE is performed with a scope which has a working length of roughly 600 millimeters or 60 centimeters. The scope itself varies in diameter or width from roughly around 3.5 millimeters to around 5.9 millimeters. Now you'll see here, the scope has got a working channel through which instruments can be passed. There's a knob up there which is for suctioning, and there's also a knob below which is for insufflation. The other end of the scope is attached to the insufflator as well as a suction along with the processor out there. Now through the instrument channel, instruments can be passed. Now the instrument channel of the TNE is quite small. It's around 2 millimeters in diameter. As a consequence of that, the instruments that can be passed through the working channel are relatively small. Nothing more than 1.8 millimeter instruments can be passed through the working channel of the TNE. You see out here some of the instruments that are used along with the TNE. Now, most studies would agree that dysphagia is the most common indication for performing a TNE. Now, when we say dysphagia, we essentially mean esophageal dysphagia. Now, I'll come to esophageal dysphagia in a minute. Now, other indications which are quite commonly seen are reflux. Now, reflux can be both gastroesophageal or laryngopharyngeal. Head and neck cancer screening, especially in populations who have a high predilection towards head and neck cancers, and also in patients who have had primaries in the head and neck region, are another common indication for performing a TNE. Globus is again, there have been studies which show that a combination of TNE and FEES is a good investigative modality for globus. And some of the interventions that can be performed with a TNE are biopsies, tracheoesophageal punctures, dilatations, which we'll all see in detail in a little while. Now, as I was mentioning, esophageal dysphagia. You see, esophageal dysphagia has symptoms slightly different from oropharyngeal dysphagia. Here, there's usually dysphagia for solids and liquids or liquids associated with some retrosternal discomfort, sometimes with regurgitation, sometimes with some heartburn, also occasionally associated with weight loss. Studies have said that roughly around 60 to 80% of the patients can reasonably accurately localize their symptoms. So the entire purpose of making all this conversation is to let us know that the first investigative modality might depend on a lot on the patient's symptomatology, how the patients localize their symptoms. If it's retrosternal, probably a TNE would be a better investigative modality than a FEES. Now, the TNE enjoys some obvious advantages of the conventional OGD-scopy. The primary or the first one being that it does not require any general anesthesia or sedation. As a consequence of that, post-procedural surveillance is not required, which brings down the cost of a TNE considerably. Studies again have shown that an unsedated TNE and an unsedated OGD-scopy patients tolerate the TNE far better. And finally, one of the most important things is it serves as an excellent pan-endoscopic tool. When I say a pan-endoscopic tool, when we perform a TNE, we can do a nasal endoscopy, a video laryngoscopy, an oropharyngoscopy, as well as the esophagoscopy, all at the same time with the TNE. It serves as an excellent tool for a one-stop diagnosis for patients who we might be looking for an occult primary and who need probably surveillances for head and neck cancers. Some centers prefer to do this in this lying down position, but then most centers prefer to do a TNE in the sitting position. The patient is asked to be NBM for around 4 hours prior to the procedure. Some local anesthesia is sprayed in the throat, while around 5 to 10 minutes before the procedure. We don't recommend spraying the throat too much. This is the reason. You see out here, when the pharynx loses its sensation, a lot of saliva starts pooling in the pharynx. As a consequence, the patient might start aspirating some of the saliva, making the patient extremely uncomfortable. So it's not wise to spray the throat too much, just a little amount of spray, and that usually works. Now, while negotiating the endoscope through the nose, for obvious reasons, we need to go in through the more open, or rather the more accommodative nostril. So what can be done is a sniff test can be performed, wherein we know which nostril or which nasal cavity gives a better air blast. Or conversely, what can be done, or what I usually like to do, is do a meatoscopy like this. Sorry. Where we go in through each nasal cavities, see which is the roomier nasal cavity, and then eventually pass the TNE through that nasal cavity. Now, after having seen the larynx, the oropharynx, the next point, or a point which is of slight concern as well as a little problematic, is visualizing the upper esophageal sphincter or the cricopharynx. Now, this is how we usually like to do it. We ask the patient to repeatedly swallow. As the upper esophageal sphincter opens up, you have a quick view of the cricopharynx or the upper esophageal sphincter. If you hold the scope above the larynx, above the upper esophageal sphincter, and you can have a look here. Conversely, some centers or some people try to do something called a trumpet maneuver, which also opens up the hypopharynx, and you can visualize the US region. Now, as we advance the scope through the esophagus, we need to keep insufflating air. However, one point of advice is we don't keep on insufflating air continuously. What happens is the patient's stomach, sorry, what happens is the patient's stomach fills up with air and he keeps belching. It makes the patient extremely uncomfortable. So a good idea is to keep insufflating intermittently so that the esophagus keeps open up, it keeps patent, you can visualize the esophagus. This is how we go in through the esophagus. So there are times when we don't insufflate, and then there are times that we keep insufflating. As we advance through the esophagus, we need to see the mucosa or any breaks, any ulcerations, any tumors. What can also be done is something called a chromoendoscopy, an eye scanning. This is an eye scan procedure, also called chromoendoscopy. The mucosa can be seen better on a chromoendoscopy. You can appreciate any obvious lesions, any mucosal breaks better with an eye scan technology or a chromoendoscopy. Now, as we approach the lower end of the esophagus, the point of importance out here is the Z line. The Z line is the squamocolumnar junction of the gastroesophagus. Here, you notice that there's an obvious change in the mucosa. Now, the Z line is very important. The Z line needs to be circular and reasonably smooth. So there's something called a Z line appearance grading system based on how the Z line is looking. If it's too ragged, if there are tongues of mucosa or tongues of columnar mucosa coming into the esophagus, then that is highly suspicious. Biopsies need to be taken from there. A Z line normally should appear round, circular, smooth. Next up is the lower esophageal sphincter. The lower esophageal sphincter ideally remains in a closed position. However, when we visualize the lower esophageal sphincter from above, before negotiating past it, it should appear closed. It should not appear patulous. It should not appear open, gaping. So these are all signs that there's a possible reflux coming in, or also possibility look for a hiatus hernia out here. The lower esophageal sphincter is negotiated by asking the patient to swallow, so that along with the swallow, we move in slowly and gently into the stomach. Now, once inside the stomach, we need to look at the stomach mucosa, the rugae, any obvious changes out here. and look at the lower end of the stomach or the duodenogastro junction. Once that's done, we begin our journey back. But the journey back usually requires even lesser insufflation as compared to the journey forward because the scope itself cannulates the esophagus. Also, what can be appreciated in the journey back is the secondary peristaltic movements that are seen out here in the esophagus. And one last thing that can be noted or noticed during the journey back is the upper esophageal sphincter once again as we leave the esophagus and come into the pharynx. So any condition which causes esophageal dysphagia either will cause a structural abnormality in the esophagus or have a motility disorder of the esophagus. Some of the common conditions that we encounter on TNE are strictures, mucosal rings, occasional hiatus hernia, tumors, occasional esophageal infections, reflux changes, that is, occasional diverticular, foreign bodies, and of course, motility disorders, which we are going to discuss in a little while. I'll just play short videos of some of the more common conditions that we encounter and then discuss each of them. Among infections, I would say that probably fungal infections and that the candidal infection is probably one of the most common infections. What can be done out here is the look usually is diagnostic enough, but then a biopsy can be taken from this along with a TNE. I'll just demonstrate in a little while how. Reflux esophagitis is probably the most common condition one can encounter during a TNE examination. Now, how does a reflux esophagitis appear? It appears as mucosal breaks in the esophageal mucosa. There's again a grading system for the reflux esophagitis, which is called the Los Angeles grading system, and it is graded from A to D depending on the area which is having a mucosal break. This out here is how mucosal breaks begin to appear in cases of reflux esophagitis. You can occasionally see a cricopharyngeal sphincter, especially in patients who have undergone radiotherapy. This again needs us to visualize the cricopharynx from above. And thankfully, with the TNE, we can also treat these sort of strictures. I'll just demonstrate how in a little while. As I said, you can catch the occasional esophageal diverticula. What we need to be very careful about is these esophageal diverticula have very thin walls. So we should not go too close to them or start probing them. We might cause an accidental esophageal rupture or a perforation. Usually these patients present with halitosis, regurgitation of food, and sometimes esophageal diverticula can be quite small, and we need to be a little suspicious in patients who have symptoms akin to an esophageal diverticula to spot one. Can have the occasional foreign bodies. What's also important out here is to know that the TNE has got a small working channel, and since it's got a small working channel, the scope, the instruments that can be passed through the working channel are quite small, and hence very large foreign bodies are beyond the ken of a TNE. You usually have to refer them to a gastroenterology colleagues or do a rigid esophagoscopy for them. Foreign bodies which have a sharper edge can be grasped with the forceps associated with a TNE. And finally, as I was saying, motility disorders. Motility disorders can be diagnosed by giving patients oral feeds and then doing a TNE examination at the same time and watching the movement of the feeds through the esophagus. This is how we do it. It's called GOOS, or endoscopic evaluation of esophageal swelling, where you can pursue the food that's being given to the patient right down to the lower esophageal sphincter and as it drops into the stomach. So the food passage, we look for the food passage, the continuous movement of the food, any residue or stasis of food in the esophagus, and secondary peristaltic movements which clear the rest of the feeds which are there in the esophagus. So as I was saying, in patients who are having candidal esophagitis, something called a brush biopsy can be taken, wherein You pass a brush through the esophagus, into the esophagus through the working channel of the scope, and just take a little of the sample and send it for examination. And that will give you a report too, if you need a report before starting your medications. One of the more common interventions that are normally done with a TNE is biopsy. While the biopsies that are taken through a TNE can be quite good, representative. What needs to be ascertained is that we are not biopsying something blue looking within the esophagus. They could be varices, they'll bleed torrentially. We need to be a little careful while taking a biopsy in the esophagus. Our biopsies through the TNE can be quite satisfactory and yield very good results. There are studies to that effect too. Again, as I was mentioning, for strictures, a TNE can be passed through the nose while a bougie or a balloon is passed through the mouth to perform a dilatation of the stricture. This is how a bougie dilatation can be done under TNE guidance. When we pass a bougie into the cricopharynx under TNE guidance, keep it there and then come back. Same thing can be done with a balloon. So Barrett's esophagus, as I was mentioning, Z-line is a very important landmark, and Barrett's esophagus is quite a common occurrence. So biopsies for screening are something that can be done conventionally when you believe that the Z-line has been breached or the Z-line has come proximally. This is how we do it. We take 4-quadrant biopsies from every 2 centimeters of mucosa which you feel are abnormal in the esophagus as we come proximally from the gastric end and upwards. The 4-quadrant biopsies need to be taken. And finally, secondary tracheoesophageal tinctures can be done under TNE guidance in the OPD itself, wherein we introduce the TNE inside, insufflate the esophagus, and through the stoma, pass the trocar and the guide wire, which can then be pulled out through the mouth. The blue guide wire, as you see, can be pulled out through the mouth, and then the TEP mounted on it, and then again pulled back at the tracheoesophageal puncture site. So this is an excellent tool for performing a secondary tracheoesophageal puncture in the OPD itself. Finally, some non-esophagoscopy uses for a TNE. One of them is, of course, doing a tracheoscopy, where we can advance the TNE into the trachea. And also perform some procedures in the trachea. This is, of course, for a case of tracheoesophageal fistula, but then it can just be done for a routine tracheoscopy also. This is where we remove a granulation which is there in the trachea with TNE. These are just some parallel uses that can be implemented. TNE. As I was mentioning, the TNE is comparable to the conventional EGD scope for both detection of gastric neoplasms as well as detection of Barrett's and reflux esophagitis. Also, it has very satisfactory outcomes in terms of biopsies of lesions, which is comparable to your conventional EGD scopies. There are some limitations, of course, to the procedure. Around 10% of patients negotiating a TNE through the nose may be difficult. Some patients who are hypersensitive gag reflex, it's very difficult to negotiate through the oropharynx into the esophagus. They may yet require sedation. Uh, the, not being gastric or gastroenterologists may miss lower gastric lesions when the TNE cannot see adequately. Again, larger foreign bodies, so you cannot grasp the present armamentarium of instruments, and slightly, if there's a modification of the instruments or if the TNE working channel can be enlarged slightly, I think that difficulty may be overcome for obvious reasons. Pediatric population, you cannot do a TNE. Complications are fairly rare. The occasional epistaxis, some pain and discomfort for the patient for the duration of the TNE. For that, I would recommend that just going through the roomier nasal cavity, and usually the discomfort is considerably less. There's only been one case of esophageal perforation ever reported in literature, and that's a fairly rare occurrence. So I think this is where I conclude. We know that the TNE has served as an excellent pan-endoscopic tool. It's a small procedure, requires anywhere between 5 to 15 minutes, depending on what you want to do. It's safe, comfortable. You see out here this gentleman, and the scope is well within the stomach, and the gentleman is sitting comfortably out there without a grimace on his face. And I would still recommend it as the first investigative modality whenever you suspect esophageal dysphagia in the patient. Thank you for hearing out.
Thank you, Doctor. Thank you, Dr. Bhaumik. Am I audible? Am I audible?
Hello.
Yes, yes, you are.
Hello? Hello?
Hello. Yes, yes.
Yes, yes. Thank you,
Dr.
Dr.
Manish
Bhaumik, for the
Munjal
wonderful
here.
lecture.
Yeah. He has put himself on mute, I think. Yeah.
Yeah.
Yeah, you are audible. Yes, yes.
Yeah. Our next speaker is Dr. Manish Munjal. A few lines of introduction about Dr. Munjal. Dr. Munjal is a full-time honorary consultant at Sir Gangaram Hospital, New Delhi. He has a vast experience in teaching DNB medical students and has an experience of 17 years post PG, post PG, 17 years of experience in ENT and in the field of laryngology and airway. He has trained with renowned laryngologists and voice surgeons in Portland, Oregon, UCLA, California, Manchester, UK, and he has set up North India's first of its kind K Pantex Voice Clinic at Sir Gangaram Hospital for special care of voice and swallowing disorders. We welcome you, sir, and it is an honor to have you over here. Over to you.
Thank you so much. It's always a good omen to start with my very close friend, Dr. Nilanjan Bhaumik. He has been such a great support. DMCH Pune, in many ways, has mentored everybody in voice and airway and dysphagia issues. And we are part of the same organization now, Laryngology and Voice Association. And I wish to make it grow further along with support of people, and of course we have our seniors for that blessing. So what perhaps Dr. Nilanjan talked about, transnasal esophagoscopy is actually a point even ahead of what we normally do for this condition, which is aspiration. And in this situation, although it is also later on imminently connected with how your rest of the food pipe and stomach behaves, but an initial assessment on the part of the ENT surgeon is what also defines the investigation for aspiration. So moving around with that, well, about aspiration, basically it's not just a disability. And would you be not surprised to know that aspiration now remains the single largest reason for post-stroke long-term mortality in patients who had a stroke. The figure goes in early millions, and there is basically still no guideline of how we treat it and how we kind of prevent it, or what is the norm to be followed all the time. And in fact, being such a big caseload with an elderly population, almost 22 to 65% from small to big things have aspiration, and it really is a poor prognosis in terms of recovery, because people keep on having these chest infections. They have to stay prolonged in an hospital. The mortality is even more mind-boggling. In spite of spending millions in the ICU units and coming out of stroke, in post CVA patients, there's a high mortality, and who have already suffered a cardiac arrest. JAMA Journal describes almost 50% post-stroke cardiac arrest mortality, and primary causes aspiration pneumonia. And even in those things whom you don't feel, a large percentage, that's why 20 to 65%, they are silent aspirators, where you really don't even know, including the neurologist and the physicians, that the person is suffering from aspiration. When we talk about aspiration, it cannot be something hanging in the air. It is imminently connected to when the person starts to swallow. A person who is on an intubation is airway protected by a tube inside his trachea, like a tracheostomy or a endotracheal tube, and is not conscious, will probably not aspirate, or maybe very little. But a person who is getting conscious, that's a sad part also. When he starts to swallow, he starts having this thing. So any treatment or any investigation of aspiration has to be linked to the treatment of swallowing and investigation of swallowing. And therefore, dysphagia further defines any difficulty in progression of the bolus of secretions through cavities of the upper digestive tract, while being trying to kept away from the airway. So if it is not being there, then it is also dysphagia. And interpretations are really akin to modern art, poorly understood. Everybody has his own algorithms. There are too many factors, too many interpretations, too many myths and denials, and also poorly reproducible tests. The causes are the same as dysphagia mainly, only the order changes. For example, in dysphagia, obstructive causes would be first, like growths, infection, large cysts, foreign bodies, osteophytes, or restrictive conditions like dentation, jaw problems, scars, fibrosis. Probably in aspiration, put in coordination to post-severe strokes, palsies, Parkinson's, MNDs as that's motor neuron disease as higher. And of course, a small subset of not explainable types of aspiration. Going in details, the diseases may be the ones that I've a little bit talked about, but even more on MRI, you might find sclerosis, MS, brain injuries, then malignancies, and of course, sequel of radiotherapy, autoimmune diseases, reflux infections, thyroids, congenital abnormalities. We are not touching too much of pediatric aspiration syndromes. This is all about adults that I'm speaking, would have become very out of scope kind of a topic. Psychogenic, then disorders, various disorders of the upper esophageal sphincter dysfunction as well. The problem lies in this part, right from the oral part, which is divided into the oral preparatory and oral transit phase, to the second phase where the main problem is defined, that is the pharyngeal phase, from where the bolus becomes a little bit involuntary and goes to the esophagus. And if you look at the coordination of these centers in the brain, you would find that oral is a large part is voluntary because it is controlled by cortical and subcortical brains, and only diffuse large injuries would start causing problems there. Whereas the pharyngeal phase would be affected by a very early infarct into the brainstem or the pontine area, like a lateral medullary or a MCA left side or a right side infarct. And esophageal doesn't get too much affected by strokes because it is mostly of autonomic inputs. But by and large, strokes happen due to coordination of all these systems, and we need to know. And why? Because when the swelling starts in a person who's recovering from a CVA or from a post sequelae of infection, the pressure generating system has to start. The bolus always moves from a high pressure to a next lower pressure with muscles compressing each other. And if there's a problem in anatomy or a neuromuscular dysfunction in any one area, where there is loss of individual pressure gradient, it will lead to the problem. So what do we have when we see a patient of aspiration? We have to take a history and clinical assessment. We have a few direct bedside oral challenges. These days, we would the endoscopy, a very useful. Hello.
Hello.
Hello. Did we get lost somewhere? Huh?
Yes, sir. We lost you.
Can you just let me know, because I didn't realize when we get lost. I was just speaking all the time. Where did we lose? In what part of the this thing? Hello?
Sir, I think last slide. No. Can you
Okay.
next slide?
Yeah, I'll go back. The tools
Yeah,
for
this one.
evaluation. Hello?
This one. We were
Okay.
discussing.
Thank God. I thought I've been lost for a long time. Sorry. So tools of evaluation, I'll go back again. These are the various tools that we have. Uh, History and clinical assessment, bedside oral challenges, a direct endoscopy, a video fluoroscopy that is sometimes required. And as Dr. Nilanjan told about transnasal esophagoscopy, it can be a very useful tool and also protective tool for aspiration when you are treating such a patient. And of course, there are investigative tools like high resolution manometry and electrodiagnostic tests. These are important to be noted when you're putting them up. In the history, you have to although know what caused all this, like the conditions that we have listed and the comorbidities, but single factors like age, getting more than a particular, that is 65 years and above, is an important marker for increased aspiration. What is the cooperation level of the patient? Because all the feedbacks and all that have to be done is an important thing. Whether it is an acute or a chronic event is to be noted, because that determines our rehabilitative therapy. What has been done for it in the past? Were there any severe coughing and choking events that before the person has come to you? And various other things that we will be talking about in this. You can send forms like GOOS forms, that is gurgling evaluation tests. You can also have EAT 10 objective tests. Of course, these are important because these scales are represented and used only in situations where you have to report the problem and objectivize it. But at the end of the day, nothing remains too much standard. So you have to come down to your own clinical examination, but it is always better if you have a structured one. So first of all, the things that you must ask as an examiner for aspiration is whether the patient at all can be assessed. So in this case, if the person can be assessed, it's according to his general condition. You must make up your mind when you're about to examine whether you're looking at a structural or a functional aspiration, or maybe inorganic, as I told earlier. And is the clinical examination going to be enough, or are you going to need more? Would you need more testing? What immediate measures could be undertaken, because your treatment might start and with directions then and there, and whether there are any risks associated. When we talk about local examination, when the person is there in front of you on the bedside or in the outpatient department, we have to do a proper oromotor examination, which starts from the lip itself. We have to see what is the pursing of the lips like, what is the range of the motion, strength and symmetry of the cheeks, as well as the tongue, whether it is in drooling that is happening in the person, how is he protruding, is he protruding symmetrically, what is the bulk of the tongue looking like, is the person's voice, your ears should work, is the voice a little bit gurgly and sounds as if it is filled with secretions, is the person's gag reflex, which you use a simple tongue depressor and then use a cotton bud to just tweak the posterior pharyngeal wall, weak or absent, very important test. Then finally look at the laryngeal elevation. When with each swallow, is the hyoid and the thyroid structure moving by around 2 centimeters or more? If it is, it's a good sign. And is it symmetrical? Then how the person is having a cough? Is it voluntary? Is it involuntary? Is he able to form a completed bark cough? A little bit of chest auscultation is important, whether you're finding any conductive or secretory sounds. And of course, while you do any test that you see, is there a fluctuation in oxygen levels? Because even the bolus of saliva that goes down and in causes a little bit of that. For example, this person, I would think, was aspirating. Can you hear the audio? If you can't, just let me know. Very bad larynx because of caustic poisoning, but as I can see, almost no difficulty in clearing the throat. Whereas this person who's finding monotonous, when he's constantly clearing, I'm asking most of the questions, but the way he's clearing the throat and telling me, he found that he has a little bit of a problem. Now look at this further extreme case of a child who's just getting treated. The fact that he's trying to cough the things out, even his normal larynx might be having secretions in that. The way you can ask him to speak and please, but the way the breathy dysphonia is there is a good enough sign, clinical bedside sign of aspiration. Coming to that, when you see a patient whom you want to check further for an aspiration, you can do a structure aspiration, and you see the tongue motor control, how the person is swallowing. Even a reasonably well-looking patient can have her or own compensatory strategies, and aspiration to might not be the aspiration to them, and in the various areas, and aspiration is being prevented by themselves. Once you are sure that the person is not frankly aspirating, like the child in that case, where you don't need to do these challenge tests, you can think of an oral challenge with water. It can be plain water if the person is not tracheostomized, which will just give you an idea. It can be colored water when the person is having a tracheostomy tube, so that you can see where it is going. We normally go for beetroot red dye or the green apple dye. And on the side furnaces, you keep on giving around 2 ml constant feeds every 2-3 minutes. Provided the first feed is successful and doesn't look like aspiration. And then keenly watch the person for a few minutes after cooperation is elicited for oral preparation, transit time, what is the head movement, how did they elevate the larynx? Did they clear the throat? And what is the speech while doing such things? For tracheostomy patients, one must do a suction after that. For example, this is what a bedside situation could be there. We have given this, and then we are asking the person, this is a part of the rehabilitation. Keep on giving it after a few minutes, once even the thing is going well. And then if you're not sure, after decuffing, just do a little bit of a cuff elicitation and see whether the thing has come down. There could be some limitations in some cases. They might seem very good with the oral phase, but as you see in this case, the girl is simply not taking it inside, and there's constant drooling of saliva and also the secretions. So some limitations of this bedside challenge can be there. So we have to think of the unmet needs, and we can see that although the assessment serves well for us in some cases, we need objective assessment, we need risk source. How do we prognosticate? How do we give a biofeedback or rehabilitate to the patient? So in this case, we would like to go for more objective tests like video fluoroscopy, which is considered a gold standard from a long time, but has to be seen in a different perspective. We test different consistency of food. It is available in almost every hospital where there's an X-ray unit with fluoroscopy and can be done with a minimum coordination with the department. It gives you coordinates where the food is going bad or where the liquid is going. It gives you a real-time assessment. It's physiological. The only thing, it cannot be repeated. And as you can see, you have these barium meal. I'm just running a little bit because I know I need to speak a little bit for in time. And we have to tilt the gantry to 90 degrees so that a sitting up flexible endoscopy can be done. And once you give this fluid through the mouth, as you can see, just ask the patient to freely take it. And such beautifully you'll see in the vallicula and all. I'll just run it again. When the person takes it, you see the vallicular feeding, and you will see the food holding on, and you can stop the thing at that time where you feel the contrast is going down. So you can see probably the whole transit going into the food pipe, and it's a very useful test to know such situations where there's aspiration. For example, in this patient, although the contrast did go into the esophagus, but you can see a considerable stream of contrast going into the trachea as well. So this is frank aspiration, and you can see in some cases where there are things like Zenker's diverticulum, which are pushing the contrast up back and pushing it into the trachea. And of course, some other reasons where there may or may not be aspiration. So while we know the advantages, we do have to also assume the person should be able to come to the hospital room. Many severe patients can't do that. You can do it only for a particular time because it involves radiation exposure. Then you have to have expensive resources like personal technicians and all. It cannot be done absolutely according to your whim fancies, and there's need for contrast. So there we have situations like video endoscopy, where we would like to talk about Susan Langmore, who started the real assessment of swallowing and aspiration assessment by developing the FEAS, the fiber optic endoscopic evaluation of swallowing, and now also PESS, where there's sensory evaluation of swallowing also for aspiration especially. It has two parts. And the first part is just to examine and see the function of larynx and pharynx and how normal secretions are managed. And the second part is after swallowing different kinds and consistency of liquid to test for aspiration. So if we see this gentleman in this case and see how he's swallowing, I'm just running down the video, going down into the throat, just examining him. We have not given any contrast, how the secretions are standing in the post-cricoid region, and with every breath, although he's clearing them, but they seem to be bothering him and getting sucked in this thing. So there's clearly a case where we are trying to investigate him for a bulbar or a suprabulbar cause. And if you take the down further endoscope, you will see that he will also has a sensory issue because you can take it down till the trachea in this case. So the best way to do it is always in a video endoscopy manner, and try to stay away from the cough range of the patient. Otherwise, you're going to have a lot of infections yourself. So the fishing pole position is considered quite good for this. The parameters that are understood and known for the FEAS examination will include the oral persistence time and residue, how much was the transit time, what are the pharyngeal contractions looking like, are they weak or strong, how's the cough reflex, how's the laryngeal injection, that is how is the contrast touching the vocal cords, is there actual transit, like you saw in that case, saliva going inside or not into the trachea, which is the negative sign. And then you go three consistencies in order of preference. First of all, semi-solids, then dried, and then liquids. But it is the liquids that actually test you the most. And this is how we make the consistency. We crush biscuits, we put apple green dye, form the same thing with the thing, and therefore you can see you can do it even with a with the Ryle's tube in position, and you have to prompt them. That's why you will have to see a lot of these things. Sometimes the patients do have a coordination, and you can see simply dye is not going too well inside. And in this case, for example, you will see a lot of hypopharyngeal problem on the right side. On the left, you see pharyngeal residue in the vallicula itself. So various situations can be seen in such cases. And the worst scenario you sometimes would be seeing, my video got stuck always. Just a minute. I'll come to that if I can. Just a second. Sorry, I'll jump that one. So if you have a situation where the interpretation, I'll just try to do it one last time. It's a good video. Okay, let me try from here somewhere. Yeah. So if you see, this is the old laryngoscope. This is my bedside laryngoscope, which I take because everywhere you can't take the K-Pentax videoscope. This is the old one. But after giving a colored food contrast, where we actually did a white dye contrast, a barium type of a contrast in the situation, we found that there was a consistent fluttering of secretions and actually penetration inside the cavity. So depending on that, you have to know the various interpretations, like was there an oral issue where there was a delayed time of swallow, how did the person reduce the clearance, how was the laryngeal volving, and then later on we can bring out prognosis for the same. Most important scale that is for aspiration is the PA scale, where it's called the penetration aspiration scale, and the grade from 1 to 8, in which 1 is that the person doesn't have any issues, but in grade 2 down to grade 3 we have airway issue, that the thing remains till the level of vocal cords and then is ejected. It remains above the vocal cords, not ejected, then it contracts the vocal cord and ejected from the airway. So from absolute no problem, the last one is when it passes through the vocal cord and no problem, no effort to clear it happens. Based on that, there are various levels of assessment in ASHA scale, that is American Speech and Association Hearing Scale, where they say it starts from the mild dysphagia. The first one where everything was going down without anything was a very high level, where you have a scale of 1 and 2 and 3, where the person has severe dysphagia, mark them, and patient is unable to clear anything. And in such cases, and the earlier one where the level 7 is there, where the normal diet and every strategy can be taken. So ultimately, we do have objective recommendations for this based on this by ASHA, where they actually tell you where the level 1 is not able to safely do anything, the level 7 can do independent. So by the FEAS methodology and the VBSS, you can give recommendations for the same. Further improvements, of course, are through transnasal esophagoscopy. I'll not go in detail because Dr. Bhaumik has already told them about them. The only thing that a person can use a TNE for aspiration assessment is when you are actually suspecting that there will be a lot of aspiration and you want to clear the secretions, like in bulbar palsies. And of course, for other screening methodologies in GERD and dysphagia, globus, etc. One thing which you use occasionally, where like in the a healthy case where there was sudden onset of aspiration, we didn't know what the meaning reason was. You do high resolution manometry with sensors, and when you have to actually know where the problem is, it's in the weak pharyngeal squeeze, pooling residue, it's a weakness, or it's actually a strength of the overstrength of the cricopharynx muscle, and in globus, which is causing aspiration. This thing is very helpful. And also surface electromyography, or the VitaStim, where you put electrodes all over, and without invasion, you can check the level of different muscle groups like the myoid, the masseter, the submental areas, and the infrahyoid muscle. So my conclusion in this is that when you are testing for aspiration, if a person is conscious, as soon as he comes out of consciousness in a severe, he deserves a swallowing assessment. The younger the patient, the better the prognosis. I said over 65, very bad. And acute neurological events must be allowed to pass, and then only rehabilitation must be done. Tracheostomy patients, even due to tracheostomy, fail the dye test. Do not put the person to dungeon. If the dye test has failed once, it could be due to psychological methodology, and due to structural restriction, must repeat it as early as possible, within a day or two if possible. And oral challenger clearance must be subjected to other tests. One test clearance doesn't mean that the person is doing well. Microscopic aspiration is as deadly and should be looked into. And holistic multi-speciality team approach, neurologist, ENT, speech therapist, radiologist, all these must be involved. And empathy, of course. So happy to announce from Delhi side, we are holding the annual VoiceCon in a big way now at Delhi and Gurgaon combined. I'd like to extend whoever is there. Dr. Sachin has assured me that things will be also be sent through webcast to everybody. So those who can come, most welcome. Those who can't are definitely going to be benefited by its webcasts. And as a pre-conference to it, at Ganganam Hospital, we are holding a live surgery workshop for voice, airway, and lasers. We hope to have good, interesting cases and very eminent faculty, all of these. And some of these would be there in person to operate for and show these cases to you. So thank you from Delhi and from Ganganam Hospital, and I hand the mic back to you, sir. Thank you.
Thank you so much, Dr. Munjal, sir, for the wonderful lecture. It is always a delight to host you.
Thank you, thank you, thank you so much. Thank you for this thing. I'm sorry, there was a time when I could not, didn't know that my scheme was not being, but I hope it was for a small time, right?
Yeah. So
you can shift on to the next speaker. Thank you.
Yeah. So our next speaker is Dr. Sachin Gandhi. Dr. Sachin Gandhi is a senior consultant and director of the Voice Clinic, Dinanath Mangeshkar Hospital, Pune, India. He is the founder president of the Laryngology and Voice Association. He is also the founder president of the Asia Pacific Laryngology Association. In 2017, he was awarded the prestigious FRCS by the Royal College of Surgeons, UK. And since 2017, he has been mentoring senior clinical fellows in laryngology. And he's the director of senior clinical fellowship accredited by the Royal College of Surgeons, which is the first and the only fellowship outside of UK and Ireland, which is training ENT surgeons. Needless to say, he has been an organizer of various conferences and workshops, and over the past 20 years, and since 2015, all of them have been accredited by the Royal College of Surgeons, UK. We welcome you on board, sir, and over to you.
Thank you, Darshil, for the kind words. Till the presentation is there, I would like to welcome all of you again. And as a surgeon, we are always looking in the cases which we can operate. Swallowing is such a vast specialty, started mainly to treat or manage the cases having neurological problems. Then it can expanded into treatment of patients undergoing head and neck cancers, surgeries, as well as radiation, and managing these patients also forms a good bulk these days. Pediatric dysphagia has also been a part of medical and surgical management of the patients with swallowing disorders. We have just started treating, managing the patients who have got obstructive lesions of the aerodigestive tract manifesting as aspiration dysphagia. Good amount of work is required again to expand the surgical indications and treat many of the patients who really need the surgeries that we are going to go along the presentation. We have seen this basically is a oropharyngeal motor dysfunction. Various factors to it: cricopharyngeal, Zenker's diverticulum, inclusion body myositis, and there are multiple other neurological pathologies which would present as a case of dysphagia or aspiration. When we really go in for surgical management, failure of conservative management, which includes medical management as well as swallowing therapy, exercises. The main thing we look at is basically protect the airway from aspiration of fluids as well as solids in many of the cases. Concern for the life-threatening indications or incidences of aspiration. Next is ameliorate dysphagia. So solve the problem which has resulted in dysphagia. It could be for long-term need for supplemental alimentation. So nutritional needs for the patients who have got chronic neurological disorders which are not being managed by medicines or swallowing therapy would need supplemental alimentation. And of course, correcting the anatomical problems and bypassing the obstructing lesion. It could be a neurological disease, muscular disease, a systemic disease, or effects of aging, trauma, intracranial lesions, as well as head and neck surgery, which would present finally as oropharyngeal motor dysfunction. We are going to see this as we go along the cases which we treat surgically. Dysphagia of oropharyngeal motor dysfunction, cricopharyngeal myotomy, or we can give surgical access for the enteral feeding. Cricopharyngeal myotomy can be done transcervically, that is the external approach, or there are endoscopic approaches as well to perform cricopharyngeal myotomy to open up the cricopharyngeal sphincter and allow swallowing. Endoscopic approach also can be used for Zenker's diverticulum. Endoscopic approach has got risk factors like pneumomediastinum or esophageal perforation. Not really more than 0.1%, but still we should remember about possibility of pneumomediastinum in cases of endoscopic approach. These are actually cricopharyngeal myotomy in which you pass in the specifically designed hypopharyngoscope and divide the partition to open up the cricopharyngeal passage. For the enteral feeding, either you can go in for surgical gastrostomy, or there are methods available now in various gastroenterological clinic like percutaneous endoscopic gastrostomy. It could be done along with radiological assistance like percutaneous radiology gastrostomy. Again, you can do it with fluoroscopically guided radiological assistance, where it's very difficult for the passage of endoscope or very systemically ill patients. Now, coming back to the problems we face in our clinic, and that is chronic aspiration. To close up the airway or protect the airway from aspiration, there are multiple methods in which you can close up the airway and prevent the aspiration. The time tested has been do a tracheostomy and inflate the cuff. That will allow patients to have the feeding without any chances of aspiration. But there are cases in which an aspiration has been reported along the side of the cuff. So time and tested method is tracheostomy. If you want to avoid tracheostomy, then you can close up the laryngeal inlet with suturing the epiglottis, to the aryepiglottic folds. Now, what's going to happen as far as phonation is concerned? Phonation is going to get hampered in these patients. But for chronic aspiration, which has failed all possible lines of treatment, this could be one of the methods which could be tried to prevent aspiration: closure of laryngeal inlet with the help of epiglottis suturing onto the aryepiglottic folds. If you want to prevent or if you want to really close it below the supraglottis, then there are methods or techniques described in which you take sutures between both the vocal cords and close up the glottis itself. Now, if you close up the glottis, then the phonation is really going to be hampered or lost. But if the supraglottic closure doesn't work, there is another method in which you can go below and close up the glottis with suturing the vocal cords along their entire length. This is a closure of both the vocal folds. Make a raw surface on the edges of the vocal cords and take sutures transorally. We have already talked about it. Tracheostomy is the method, but then you have to deal with managing or taking care of the tracheostomy with suction and dressings and all sorts of things. there are endolaryngeal stents available in which closing down surgically of the larynx is difficult, like taking sutures. So endolaryngeal stents are also available and described. You can divert the trachea below the larynx and into the esophagus and close up the trachea below. So this is actually tracheoesophageal diversion. You can separate the larynx and trachea altogether and close up the subglottis here and open up the trachea onto the neck. There are methods available which would spare the voice, or patients can phonate after the surgery, but these are surgical methods, what we call them as partial laryngectomies. So partial cricoidotomy, subperichondrial cricoidotomy, or what we say as narrow field laryngectomy. These methods or partial laryngectomies have been described, and these give good amount of phonation after the surgery and preventing aspiration as well. One thing everybody of us should make it sure, patients of chronic aspiration doesn't have a tracheoesophageal fistula. And maybe a barium swallow would tell you if the tracheoesophageal fistula is causing the symptoms. Barium swallow or a CT scan with gastrographin and all contrast materials. But you have to rule out tracheoesophageal fistula in all patients of chronic aspiration with radiological as well as endoscopic methods. And there are again various methods to treat the fistulas or close down the fistulas. Esophageal stents have been working, and you can put in the esophageal stents and prevent further aspiration, especially in cases of malignancy of the thyroid gland, which really invade and open up into the trachea and esophagus, or esophageal malignancies post-radiation. So esophageal stents are working and have been practiced in many of the centers. Patients with acute unilateral vocal cord palsy, usually they present with aspiration and change in voice. But really, in few of the cases, or many of them really, in the acute phase, there is a fear of, because of aspiration and those episode of cough, when really, when they drink a small amount of liquids or solid, that aspiration creates some fear in their mind, and actually their nutrition is hampered very well. To prevent the aspiration and to really remove this sense of fear, I have been practicing injection laryngoplasty in these cases when really patients present with aspiration and change in voice. So even if, what we are really taught, any patient presenting with unilateral vocal cord palsy, you have to wait for 6 to 9 months before doing any invasive procedures or intervention, surgical intervention. But yes, patients who present with aspiration as their main symptom, even in acute cases, like even in a 1 week or 2 weeks time, you can do injection laryngoplasty and they will definitely take care of the aspiration in these cases, along with improvement in their phonation. This is a short clip of the fat augmentation. endoscopic view with a direct laryngoscope. Patient is anesthetized with the high frequency jet ventilation. You can see a cannula posteriorly here. Fat has been harvested, and with the needle which I have designed and I'm using for past almost 20 years, I inject fat anterior to the vocal process and see to it spreads all along the vocal fold. The remaining fat, really, if it comes out, you can just, rather than removing it with the forceps, you can vaporize it with a diode or a KTP laser, or just cut the bits with the scissor. Takes very good care of aspiration as well. Many of the institutes have got pediatric PICUs and NICUs, and you start getting references of cough on swallowing, chronic aspiration in children. And the simplest thing, I mean, I came to know about this pathology maybe when I started practicing swallowing specialty, and just putting in the laryngoscope, a pediatric laryngoscope, you can visualize the interarytenoid area, and then you'll be able to see, yes, there is some cleft in between, which could cause aspiration in children. And then again, there are problems of nutrition and weight gain and all these problems and chronic cough. They would land into respiratory distress as well as they go along. How to close this cleft? I mean, this cleft, then again, as per the depth of this cleft, has been classified into 4 things. Like when we start interarytenoid, grade 1, as you go along the cricoid cartilage, maybe grade 2, grade 3. As you go down up to the carina, it may be grade 4. Grade 3 and grade 4 are very difficult to treat or manage. They would need external surgery to really suture that cleft. Type 1, maybe you can take care with passing in the Ryle's tube and allow the child to grow. Type 2 and some type 3 clefts can be managed transorally by closing this interarytenoid area or this cleft with suturing, making raw surface on both the sides, and then taking sutures in between. You can pass in gel foam also in between, and take care of aspiration. Is a clip of a child who has got laryngo cleft. See, now this child has got this mucosal edema also in between the interarytenoid area. This redundant mucosa. This is a redundant mucosa which you can excise the help of a KTP or a diode laser, or you can use a CO2 laser as well. Just to avoid local bleeding, we avoid using cutting it with the scissors. Just to protect the aspiration, this is a compensatory hypertrophy of the laryngeal mucosa into the cleft. And this compensatory hypertrophy gives breathlessness, airway obstruction to the child, and then these children usually land up in tracheostomy. So this child was really referred with tracheostomy as well, the nasogastric tube. And the reason for the tracheostomy is compensatory hypertrophy of the laryngeal interarytenoid mucosa. Now just to make the airway patent, I have excised this redundant mucosa. Then with the help of KTP, CO2 or diode laser, we make the area raw by vaporizing the mucosa and then taking sutures, 2 layers of sutures to close up this cleft. See, you can see the cleft. Here you will find, you can close it in 2 layers, the laryngeal one and down into the esophagus, but a single layer also should be good enough to close this cleft. Then you can keep the child on nasogastric feeds. You can just decannulate the child and you will be back to the oral feeds. You can just do the surgery additionally to excise the redundant mucosa and the arytenoids as well. So airway is quite patent. The cleft seems to be holding on, the suture seems to be holding on, and the child goes back to normal. The intra-arytenoid area which has been sutured. This is done under GA. Check the healing. Esophageal foreign bodies, actually now we can also start doing this. Nilanjan has already shown, so I am not going to repeat the clip. But yes, with a transesophageal scope, you can manage all these cases. Reflux laryngitis, the resistant one can be managed with surgical methods like Nissen's fundoplication, or again laparoscopic fundoplication, which would be minimally invasive method. As I've told, there are cases which are coming to you for long-standing dysphagia following radiation for tonsils or head neck region. There is a lot of fibrosis in the cricopharyngeal area, and again a stepped clearing of these fibrous glands with the transoral diode or KTP laser gives them oral passage, and gastrointestinal feeding would be possible. But again, we should avoid making a raw area in one sitting, and maybe in 2 or 3 steps or stages, you can cut along the fibrous bands and make it patent. There are cases of fibrosis because of organophosphorus poisoning, and it is usually supraglottic or oropharyngeal. Again, you can take care of this with the help of transoral laser and opening up of the oropharyngeal fibrosis, getting back their nutrition and swallowing function. So this was the last sitting, and we have opened up really the supraglottis as well as the oropharynx, allowing the child to eat and phonate. Same oropharyngeal stenosis in the adults following organophosphorus poisoning. Again, organophosphorus poisoning limits itself into the supraglottis and all fibrous bands, and you have to open up really carefully in a staged manner. Now we are starting getting cases of early granulomatous lesion in the cricopharynx, in the piriform foci, and this was the case of post-radiation cricopharyngeal piriform fossa growth. And PET scan and everything was negative, but they were able to see some granulations in the piriform fossa. Now we were able to do a biopsy with TNE, transnasal esophagoscope, which turned out to be carcinoma in situ. And then with the help of KTP laser, it was cleared with a normal mucosa all along. So there are indications which are coming over to treat laryngopharyngeal malignancies. What's the future? Like we are comparing or maybe taking over the lost function to the gastroenterologist, like balloon dilatation. And balloon dilatation for cricopharyngeal stenosis, whether it's benign or maybe post-radiation, malignant cases, we can do it. And now clinics in USA, in the West, have started doing office-based transnasal balloon dilations. You just pass in transnasal ultra-thin esophagoscope, which we are using in our clinics. Along the side, you can pass on a balloon along the esophagoscope, go up to the lesion and just dilate the stricture with the help of balloon as an OPD procedures. As an OPD procedure, now available in the market by Boston Scientific Corporation, USA. I am actually in discussion with one of the manufacturer in India, that is Merrill, which is having cardiac as well as airway balloons, and they will be coming up with these balloons for transnasal OPD based balloon dilatations of the cricopharynx. Which was described by Lees in USA, and these are pictures, images from his own publication. I think, again, you are always welcome to Dinath Mangeshkar Hospital for surgical training in the simulation lab. Thank you very much for your patient hearing. We'll take up the questions after we finish the last talk.
Thank you so much, Gandhi sir, for the inspiring lecture. Our next speaker is Mrs. Vrushali Desai, ma'am. Mrs. Vrushali Desai, ma'am, is the consultant voice pathologist at Dinanath Mangeshkar Hospital and Research Center since 2011. She, after completing her bachelor's master's in speech language pathology from Aliyavar Jung Institute in Mumbai in 2001, she had a clinical attachment at North Riding Infirmary and James Cook Hospital, Middlesbrough, United Kingdom. Following which, she joined Dinanath Mangeshkar Hospital in 2011 and has been working in the area of voice diagnostics and therapy for the past 15 years. She is a core member of the Singers Clinic and the Swallowing Clinic at Dinanath Mangeshkar Hospital, Pune. We welcome you aboard, ma'am. Over to you.
Thank you very much, Dr. Darshit. A very good evening to everyone. And now we come to the last talk of today's module, that is swallowing rehabilitation. So I've tried to divide this talk into parts. First, we'll try to just have a brief overview of all the rehabilitative strategies and the different modalities that are used in swallowing rehabilitation. And then after that, we'll try to see how these strategies can be implemented in various case studies. where it will be easy to kind of correlate the clinical as well as the findings from the instrumental examination in actual treatment plans. So just a quick recap. A patient, when referred to your outpatient as with a complaint of difficulty in swallowing, or if the patient is admitted in ward facing a swallowing difficulty, undergoes a bedside examination, which includes clinical history as well as detailed assessment of the oral peripheral mechanism by the speech language pathologist. This is followed by a few tests of dysphagia screening. If these tests are passed, the patient passes these tests, then he is put on oral feeding and on the regular review and referred back to the physician. However, if there are any difficulties noted in the dysphagia screening test and the patient appears to fail on these tests, then we undergo a clinical swallowing evaluation, which is nothing but a detailed swallowing assessment. And further, he's referred for instrumental assessments such as modified barium swallow or a fiber optic endoscopic evaluation of swallowing. Following diagnosis on these tests, the patient is then treated either medically through medical line of management, the behavioral line of management, that is the swallowing rehabilitation, or the surgical mode of treatment, which we have just seen in the previous lecture. So coming to dysphagia therapy, defining goals for dysphagia therapy is a bit challenging because though we know what a normal swallow entails, we need to first establish how we are going to make the patient swallow better. So it could be by either trying to improve the amount of residues. It could be by trying to avoid the aspiration penetration. So all of these findings are first noted in the evaluations, the clinical as well as the instrumental evaluations. The first and foremost goal of dysphagia therapy is to maintain a safe swallow, that is reduce risk of aspiration as well as penetration. Also to improve the ability to eat and swallow and maintain or go back to oral feeding. And the most important again being optimizing the nutritional as well as the hydrational status of the individual while trying to manage a safe swallow. The management strategies can be very, very broadly classified as dietary modifications, compensatory techniques, and exercise rehabilitation. Exercise rehabilitation, again, includes two parts, that is the direct and indirect swallow exercises. So sometimes a patient is unfit to be taken in for oral feeding. So in that case, because he is either aspirated or penetrated during your initial screening and swallow evaluations. For these patients, we start with some indirect swallow exercises, and later on we can take him for direct swallow rehabilitation. The direct swallow exercises are nothing but the swallowing maneuvers or the step-by-step sequential swallow exercises, which could be initially started on dry swallow and then would progress to with feeds on particular consistencies. So coming to the first rehab technique is the dietary modifications. So whenever during the clinical assessments, we notice that the patient tends to aspirate on certain substances, however, is able to do well without aspiration or without any risk of penetration, then we can try and alter the bolus volume, the bolus texture, as well as the consistency. Also, the mode of delivery of the bolus. So these adjustments in bolus volume, speed, and mode of delivery are included in your dietary modifications. So a good example would be by varying textures. So sometimes liquids are difficult because fast transit of liquids could be quite risky for certain individuals who are compromised either at the airway level or at the glottic level. So by thinning the liquids is easy for patients who have a reduced tongue-based contraction or reduced pharyngeal contraction, whereas thickening the diet is usually done for patients who have poor tongue control or reduced airway closure, because a thickened diet, because of its slow movement to the pharyngeal area, can be safely taken in by the patient. However, when we are varying these textures, either through thickeners or by simply pureeing the diet, we always have the aim to progress to a more general or regular diet ultimately. The compensatory techniques are, most of these techniques are usually tried during assessments. such as during the fees exam or during a clinical swallow evaluation by the speech pathologist. So these are all short-term adjustments in the head, neck, and body, which kind of alter the flow of bolus in the oral cavity. So they control transport of bolus and prevent aspiration. And in these techniques, we teach the patient certain postural adjustments or maneuvers to compensate for whatever swallow difficulty that they might be having. These are some of the techniques that we very, very commonly use in therapy. The first one, as you can see, is the chin tuck technique, which narrows down the pharyngeal area and helps in kind of channeling the bolus in a more safer way. The second is the head tilt. Third is the head back or the chin jut, mostly given in for patients who have difficulty in oral containment, anterior bolus leakage, or patients operated for oral cancers. Then this is a head turn swallow. And the last one is a combination of a chin tuck as well as a head turn, which could be sometimes helpful in giving a safer swallow as well as redirecting bolus to the stronger side. The main difference in a compensatory versus rehabilitative strategy is that compensatory strategies, being postural adjustments, they are usually manipulated by the clinician doing the fees exam or by the therapist who's there alongside. They can be done during the exam. The benefits can be immediately seen as assessed during the scopy. The benefits are immediate, however, may not be permanent, because then it would entail the patient to use these techniques every time that they swallow. So although it is aimed to secure a safe and adequate oral intake, it requires limited cognition, and the patients can be assisted by their caregivers. However, a rehabilitative exercise, it is always aimed at actually rebuilding the swallowing function or altering the swallowing physiology over the longer term. So though it is a more intensive and long-term exercise approach, it definitely helps in rebuilding the muscle function. Though it requires good cognition on part of the patient, because the patient has to actually be cooperative and compliant in following those instructions, but the benefits are definitely permanent in this case. As I mentioned earlier, there are certain non-feeding or stimulation programs which are mainly given with the purpose of facilitating or improving the neuromuscular function and control of the oral musculature. So if the patient is unsafe for taking in any food orally, then at that point, we give these oral range of motion exercises which help to improve the jaw muscles, the tongue muscles, lip muscles, and they can help in improving the muscle ability for safe introduction of food at a later stage when direct treatment can be initiated. Direct swallow therapy includes some of the very, very commonly known exercises such as the Mendelssohn's maneuver, the super or supraglottic swallow, the Shakir's exercise, as well as effortful swallow. So the Mendelssohn's maneuver is undertaken basically for patients who have reduced laryngeal elevation, hypolaryngeal elevation, or cricopharyngeal opening. So in these cases, it serves as a compensatory as well as rehabilitative strategy because it is a postural modification. However, it has an immediate as well as a long-term effect in trying to improve the cricopharyngeal opening, in trying to improve the clearance of pyriform residues in these patients. So the patient is asked to feel while he's swallowing, and at the top of the swallow, he's asked to hold the swallow and then for a few seconds and then dry swallow. So definitely this requires a little bit of sensory as well as motor training and a lot of cognitive abilities on part of the patient. So it's a little difficult to learn and carry out. Hence, may be used a little less often. The second is a supraglottic swallow, where it's recommended for reduced airway closure because it's known to prevent entry of food into the glottis, because it tries to close the vocal folds prior to as well as during the swallow. So the patient is asked to initially trained on a dry swallow, where is asked him to breathe, then try to hold his breath. While holding his breath, try to swallow and then cough out, and which kind of clears all the residues. So these again help in improving the timing of the upper esophageal sphincter opening, the duration, improvement in the hyolaryngeal elevation, as well as improving the laryngeal closure during swallow. The Shakir exercise is a non-invasive exercise. Again, is a conservative alternative for cricopharyngeal myotomy or Botox. So can be tried on earlier during the early stages of treatment, typically taken up in patients who have excessive residues, valvular as well as pyriform sinus residues, and it's known to improve a certain set of muscles required for the upper esophageal muscle opening. And it also has shown to improve the residue clearance and thereby help in patients moving on from being tube fed for a very, very long time to being taken in for oral feeding trial. The very common used technique is the effortful swallow, which kind of does a two-way function in trying to improve the lingual force on the posterior pharyngeal wall, as well as increasing the pharyngeal pressures during swallow. So it helps in improving or clearing the valvular residues to a great extent. Recently, a lot has been studied and implemented in terms of transducer rationales, where use multiple transducers, such as the surface electromyography, to study the various muscle movements during swallow, to study the apneic phase during swallow, its duration, to study the tongue movements during swallow, as well as cervical auscultation. So the swallowing signal labs is one of the very commonly used system by the Pentax, which can help you to achieve all of these results. It can be used as an assessment as well as a therapeutic module. So now, once we know what the basic treatments regarding to dysphagia therapy are, let's move on to how FEAS exam can help us, help the clinicians to plan the course of treatment, to plan which strategies could be taken up and they could be helpful. So here on dysphagia therapy, we try to study the bolus, or the movement of bolus could start as the main benchmark, wherein depending on if the bolus is either incomplete, that is not complete clearance of the bolus, would help us map a dysphagia pattern of weak or ineffective swallow. A misdirected swallow could be because of an impaired airway protection, and the swallow could be delayed or mistimed. So first we need to see what the kind of bolus movement pattern is, and that will help us to find out the physiologic deficit related to the swallowing, and in a way help us to map where the swallowing is going wrong, or establish a pattern of dysphagia. So dysphagia therapy planning is highly dependent on these diagnostic markers on FEAS, either pooling of secretions seen, then the residues, as you can see here, there are valvular residues, swallow initiation delay happening, spillage, premature or during swallow, aspiration, either silent or audible, as seen here, and penetration, as seen here, which is that could be traced on the instrumental examination. Aspiration or penetration can also help us to interpret what is actually happening. So if the aspiration or penetration is occurring before the swallow, it could be delayed initiation. If it's during, it could be incomplete valving at the laryngeal level. If it's post swallow, then it is probably related to incomplete bolus clearance, which in turn leads to some trace aspiration. Similarly, spillage patterns can be studied. If the spillage is during the oral preparatory phase, then it could be because of poor oral containment, very commonly seen in patients with oral cancers. Or if it is at initiation of swallow, it could be because of a delayed or mistimed initiation of swallow. So these patterns, when are all observed during the FEAS exam very carefully, FEAS being a very, very dynamic exam, if we observe this, then that will help us in planning what kind of strategies we can immediately try on the patient and decide for the longer course of treatment. So the first scenario, as we studied, is an ineffective swallow or incomplete bolus clearance, leading to a lot of residues, as we can see in the valvular area, or in this particular case where it's in the valvular, as well as there is incomplete pyriform fossa clearance. So the problems here could be in tongue propulsion. It could be due to inadequate epiglottic movement. It could be due to inadequate hyolaryngeal excursion, which is kind of which could be seen in terms of epiglottic retroflexion on your FEAS, because actually during the elevation, we could see a whiteout. Could be due to problems in upper esophageal sphincter opening, the duration as well as the timing for which it is open. It could be simply because of a large bore RT, which could be impeding the flow of bolus on that side. So this is a case of copious pooling of secretions, where we see that in the baseline, there is excessive secretions seen on the swallow examination. Here we can see that the patient is taken in for swallow assessment and there is excessive pooling of secretion seen. So this shows this kind of an image on your examination. And here an immediate dietary advice would be to switch to a complete non-oral feeding method, such as the Ryle's tube or the NGT. And a more rehabilitative approach could be a combination of oromotor exercises in order to strengthen the oral musculature to get it ready for improving the dry swallow and then later introduction of food, and the Shakir's exercise, which would help in improving all of the movements responsible for clearing these residues. So this particular case showed this kind of a picture after a few sessions of Shakir's and oromotor exercises, where though the clearance of residues is still not too normal, but it's very much improved. A general management protocol for residue clearance could be a combination of dietary, compensatory, as well as rehabilitative techniques. So you could either alternate, if it's a very, very mild residue clearance problem, you can simply alternate food and liquid bolus, because by modifying the bolus volume, it helps to clear the residues which could be seen on a particular texture, such as soft solids or semi-solids. A compensatory technique such as head turn or chin tuck could be used during swallow. And the patient could be trained in therapy sessions for effortful multiple swallows during the meals, as well as a Shakir's or Mendelssohn's maneuver. The second scenario is in cases of misdirected swallow. So it could be due to incomplete valving. Valving needs to be complete at the velopharyngeal as well as the laryngeal level for a normal swallow to take place. So if there is a problem in inadequate laryngeal valving, it could lead to misdirection of the bolus, and also there could be inadequate arytenoid adduction, which could kind of compromise the airway safety. So for such patients, you give a trial of thicker liquids and see if they are able to control the transport of thicker liquids better than thin liquids. We could try and modify the bolus volume and rate of delivery, switching to a more supervised mode wherein the liquids are given through spoon rather than a cup. A compensatory strategy like a head turn to the stronger side can also be used, or a rehabilitative strategy such as supraglottic swallow or phonation exercises could be used. So this is a very, very typical finding seen in cases of neurogenic dysphagia or dysphagia post unilateral vocal cord paralysis. So any of these strategies could be tried in these cases. So this is an example of a misdirected swallow due to incomplete valving, as in vocal cord palsy post-stroke, where we see that there is aspiration as well as residues seen. So trial of thicker liquids is given, and thin liquids are stopped. And this patient is then taken up for a compensatory strategy like a head turn or chin tuck and a supraglottic swallow. This is the kind of picture that you see after few sessions of therapy, when there is no aspiration occurring, and slowly and steadily the patient can go back to a more normal or a regular diet, however, continuing the rehabilitative exercises. The third pattern of dysphagia is a delayed swallow initiation or a mistimed swallow initiation, which could give rise to spillage. As I mentioned earlier, such problems are very, very commonly encountered in patients who come to us post-surgery, following surgery for oral cancers, oral mucosa cancers, buccal cancers. So in these patients, you see that there are a lot of residues taking place, which can then later on lead to aspiration. In both these cases, you can see that there is spillage giving rise to aspiration. So though the symptoms are pharyngeal, the onset starts at the oral stage. It could be also seen in some patients of Parkinson's because of excessive tongue pumping movements. The patient is not able to contain the bolus, which causes either or anterior leakage, that is drooling of the bolus, or it could cause spillage of the bolus. So for these patients, they need to start initially with some oral range of motion exercises. Sensory stimulation in order to initiate the swallow timely could also help. And a supraglottic swallow, a Mendelssohn's maneuver, could also be helpful in improving all the movements are achieving closure at the right time. Apart from the various strategies used for swallowing rehabilitation, it is very, very important to take care of oral hygiene for all of these patients. Most of these patients which we manage, chronic aspiration patients, they are on tube feeding or a little amount of oral feeding for a very, very long time. They have compromised oral musculature issues, and hence the bacteria in the mouth could give rise to very, very bad problems. And so in addition to your traditional therapy strategies, we need to educate the patient and caregiver for a more intensive oral hygiene program in order to prevent its effect on pneumonia or any other respiratory tract infections. So to conclude, multidisciplinary management of dysphagia is very, very important in pediatric as well as adult cases. Early screening for swallow deficits is extremely important. We need to make all the physicians in all the working centers aware about the risk of aspiration and penetration, and so that we could get referrals early on for swallowing deficits. In turn, the clinicians have to be very, very aware and refer for a more detailed instrumental evaluation such as the FEES or the MBS. Trying to plan a more individualized therapy plan goes a long way in improving the status of the dysphagia individual. And of course, these plans need to be based on careful analysis and integration of evaluations, good discussion among the swallowing team. And therapy definitely helps to optimize nutrition, hydration, as well as ensure airway safety. Caregiver education is very, very important in dysphagia individuals because most of the time these individuals are going to be needing help on part of the caregivers to help them to feed or monitor their strategies during the meals. And a meticulous oral care and hygiene program needs to be implemented along with the traditional dysphagia techniques. Thank you very much for a patient list.
Thank you so much, Vrushali Desai, ma'am. Swallowing therapy is something that a lot of clinicians across various branches, like whether it is ENT, neurology, oncology, a lot of clinicians depend upon, but they do not have the knowledge of how it exactly works. So thank you so much for the informative lecture. We now move on to the question and answer session. We have got a few questions over here. This question is for Dr. Sachin Ganti, sir. The question is, what is the best way of management of esophageal stricture?
See, best way of managing esophageal stricture again is balloon dilatation. And if it is esophageal, then I think gastroenterologist would be preferred if it is lower down into the esophagus. But yes, upper esophagus, if you can, balloon dilatation would be the best possible method of choice.
Okay, sir. So there's another question in relation to this. Should we prefer a balloon or should we prefer a bougie for esophageal dilatation? How to choose between both these techniques?
Yeah, I think balloons are preferable because they give pressure only in the area of stenosis. Bougie is really going to go down, and the tip of the bougie may cause damage to the esophageal wall below. It is a blind procedure in itself. So I think balloon dilatation would be preferred over bougie dilatation.
Okay. Question in relation to this. Is there a role of rigid esophagoscope in dilatation?
See, of course, rigid esophagoscope has been used in the past when really these instruments were not, I mean, flexible laryngoscope, flexible esophagoscope, transnasal were not there. So, yes, in few of the cases, like in malignancy, where chances of esophageal rupture or maybe uh, fissulas because of trauma of poogies and balloons would be more likely. In those cases, maybe rigid esophagoscope would be more useful, in which under GA, of course, the only advantage of using flexible is it can be done under topical anesthesia. But yes, esophageal malignancies, the method of choice would be under GA with a rigid esophagoscope.
Okay. Okay. Thank you, sir. Our next question is for Dr. Manish Munjal. The question is, if there is a stage 4 laryngeal carcinoma with intractable aspiration, how to deal with it? What is the management? Stage 4 laryngeal carcinoma with intractable aspiration.
Manish, I think if Manish is not there, I would suggest to put in a stent, esophageal stent, as a method of choice in cases of terminal cancers of the esophagus. Hello?
Okay. Hello?
Yes, sir.
I think Manish is not
available.
Yes, sir. Yes, sir.
I think stents would be useful in stage 4 esophageal cancers.
Okay. Okay.
Or you can go in for esophageal, PEG, percutaneous gastrostomy, endoscopic gastrostomy. But again, endoscopy would be difficult. So I think stent and surgical gastrostomy would be useful in these cases.
Okay. Okay. Thank you so much, sir. I would like to thank Dr. Manish Munjal, sir, Dr. Vrushali ma'am, Dr. Nilanjan Bhaumik, sir, and to you for the wonderful webinar this month. The next webinar would be on the third Saturday of December, and we'll keep our delegates posted. I thank all the delegates for joining us. Are there any concluding remarks that you would like to add?
Yes, I would again thank all the delegates who have been watching this webinar. I mean, there are almost more than 800 participants, as I can see on this one from the contactor, and I would like to thank, because of the feedbacks which we are receiving. We are excited to continue this series for year 2023 as well, and it would be the calendar would be same, third Saturday of every month, 4 to 6. Instead of lectures and presentations, it would be a combination of demonstrations plus presentations, and demonstrations would be diagnostic, endoscopic procedures and surgical demonstration. So each session would have a demonstration and a presentation. The details would be communicated to all the delegates, and we hope to continue this all along. If any of you have got interest to participate in this series of lectures, presentations, demonstration as a person or as a group or as an institution, please write to us on our email, voiceclinic@gmail.com, and we would like to involve all of you, not only as listeners, but presenters as well. Thank you. Thank you.
I would just like to add one more thing. Our next webinar on swallowing disorders would be on 17th of December, and that would conclude this series of laryngology back to the basics. And from next calendar year, we'll start the next series as Dr. Gandhi just described. The next webinar would be on 17th of December. Thank you so much for attending.
See you.